There are three functions of the skin. The first one is protection. The second is thermoregulation, the regulation of our temperature. And the third one is sensation, the ability to feel touch and also detect temperature. There are several ways in which the skin of a newborn or preterm infant differs from that of an adult. The first one is the thickness of the skin. The stratum corneum, or the outermost layer of the skin in premature infants, is actually about 40 to 60% thinner than adult skin. In term infants, it can be about 30% thinner, which means that it is very, very important with barrier protection in these babies. The factors that can affect the appearance of neonate skin can actually be a long list. We have to think about ethnicity and that affecting color of skin. We have to think about things that newborns encounter, such as jaundice, that are coloring the skin differently than normal skin. And we also have to think about age. When newborns are born, they have sort of the blue mottled to purplish hue. And even as early as 24 hours after birth, that can change after there is adequate oxygen exchange. Two nursing interventions that provide protection for the preterm infant skin is making sure that any newborns are delayed as far as baths go. We don't want to disrupt any of the normal barrier or things that are there when babies are born that can actually help us if we leave them be. Bathing can also disrupt the pH in the skin, and neonates and newborns both have a little bit higher pH, which means that their barrier is a little bit more susceptible to things like bacteria. Normal variations in newborn infant skin, those can be a combination of red patches. Babies can be born with some very normal skin issues, one being things like erythema toxicum neonatorum. This is a common issue with infants that can occur in as many as 50% of all newborns. It can be unsightly, but the treatment is actually to do nothing. These lesions will go away usually within several days. The other thing that newborns can be born with is milia. These are probably one of the most common lesions in newborns, and these are just sort of pearly white cysts that sort of look like they sit just under the skin. Again, this is something that requires no treatment. It will go away on its own without any intervention. There are also common vascular lesions that babies can be born with. Port wine stains, these are flat pink to red patches that can be anywhere on the body. And these are something that should be addressed early after babies are born because over time they can thicken. So as children become teenagers and adults, these port wine stains can thicken. And so if we are able to intervene with some laser treatments very, very early in life, that can actually help these lesions to not have as many difficulties as they grow into adults. Port wine stains are a form of what we call a capillary malformation. Most people know babies can be born with things like what they call angel kisses or stork bites, or you'll hear them called salmon patches. These are all types of what we call nevus simplex. And these are lesions that will actually generally get lighter on their own, and they're different than port wine stains. They do not require any laser treatments or any intervention whatsoever. And generally, as babies grow older, those get lighter and you can't even see them. So recapping the anatomy of neonatal skin and the key characteristics. So as I mentioned before, the stratum corneum, the outermost layer, is actually much, much thinner. The coloration can be different. The way that the skin looks from the time of birth to even 24 hours can look differently. And baby skin can also look very dry after the vernix has been wiped away. So those are the typical differences between neonatal skin and mature adult skin. There are several common types of skin injuries in neonates and newborn infants. The most common would be pressure-related injuries. This is actually something that is seen very, very commonly in neonates and infants. The other would be moisture-related injury, things like diaper dermatitis. And lastly, another common injury is the tears and blisters that neonates and infants can get just from the medical tape, dressings, things of that nature. So it's very, very important to remember as a nurse that because these injuries can occur, that we're doing everything we can to prevent them. The infant skin of a term newborn is actually structurally a little bit different than adults. The epidermis is quite a bit thinner. And so this is what we have to remember, again, with injuries. Because they are fragile, we have to remember to be gentle. There are multiple phases of wound healing. The first one is hemostasis, and this is just the ability of the blood to clot if needed. And that is the first step in getting wounds to heal. The second step is inflammation. This is the skin saying that something is wrong and we have to begin to repair it. The third is proliferation. This is the rebuilding stage, the skin cells regenerating and rebuilding to get to the last stage, which is maturation. And that is basically just the skin saying, now it's time to become strong again. There have been actually many cases of skin injury if you look at data and research. The most common, as I mentioned before, is pressure-related injuries. These are things that can be prevented. So they are definitely something that nurses should consider when taking care of neonates and infants to help prevent those skin injuries and also help reduce the risk of any issues with the families. Ways in which standard NICU care practices expose immature skin to risks. These most actually do happen more often in the NICU because those are the patient population that are more at risk. One of the things that occurs commonly in the NICU is the exposure to disinfectants, alcohol, betadine, also chlorhexidine. These are all disinfectants that are used when we are practicing those interventions for those babies that need to occur to help them survive. Things like inserting peripheral IVs. it is very, very important as a nurse to make sure that we are doing everything possible to reduce the time that these disinfectants are on the skin, especially with the chlorhexidine, which will actually put immature skin at risk for burns. So if you're using chlorhexidine in any type of procedure, it's important to wipe afterwards with some sterile saline. And I also believe that if we just remember with adhesives and dressing, I have a motto that's called go low and slow. You need to be slow with removing the dressing or adhesive, and if you stay with the dressing sort of parallel to the skin and in the direction of hair growth if possible, going low and going slow will help reduce those tears that we see with adhesives and dressings. Practices for pressure injury prevention are different for neonatal patients due to their size, their age, and their level of illness. We have to remember that sometimes these neonates and these infants may have some severe illnesses other than being born premature. So you have to remember that one of the most important things for pressure injury related issues is repositioning. Just as you're taught to do with adult patients, the neonates and any infant that is going to be in the same position for long periods of time, their positions need to be adjusted and rotated. We have to remember, because of their immature skin, there can be compromised perfusion. They are obviously, their mobility is decreased. They can hold fluid retention, and they also can have some altered neurological status. So infants and neonates can't tell us that something is hurting, and so we need to make sure we're doing those assessments on their skin regularly. What I'd like to outline as best practice pearls to achieve the clinical goals of neonatal skin, including maintaining skin integrity and reducing those traumatic injury risks. So assessments, if not required by your institution to be more often, should be at least twice per shift. And one of the most important things is to remember to address any skin that is under clothing and under any dressing that is not transparent. We are used to using transparent dressings with IVs, but sometimes there are other things that require non-transparent dressings. And we also, during our assessment, need to make sure that we are looking at those and addressing and making sure that everything is looking normal. Another best practice pearl I would like to mention is using the least amount of tape possible. We are required to use dressings and things of that nature. And so if you're using any tape with adhesive, the least amount possible on the skin is best. The other thing I would like to mention is avoiding antimicrobial products on the skin, including in the baby's baths, and avoiding rubbing with cleansing of diaper changes and making sure we're getting those diapers changed often. There are several myths and fallacies and outdated beliefs regarding neonatal skincare. These are something that are always going to be out there. Some of it's cultural related. We've probably all seen those cultures where they are used to using things like olive oil on the skin. And some studies have actually shown that it's not actually safe to use that because there could be some damage to the skin barrier. This is something that you typically are going to see from parents and grandparents of certain cultures. The other sort of fallacy out there is Organic is not always better. We hear the word organic and we think automatically that that means something is good, and that actually is a false statement. Some have natural ingredients that can be irritating to the skin, things like flower essences. The most common care nursing errors that you can see in neonatal skincare practice is those of timely assessments. Some institutions have no requirements on how often the skin must be assessed, but it should be assessed quite often while you're on your shift or taking care of a neonate or an infant. Because their skin quality can change very, very quickly. So more often assessments, and as I mentioned before, making sure we're doing those assessments very, very thoroughly, looking under the clothing, looking under the dressings, actually lifting babies and looking at the backside, the backs of the head, the buttocks, any area that is prone to pressure, and using some of those devices that are available to us to help these immobile babies be repositioned comfortably. Three factors that affect the appearance of the neonate skin. First would be color. So color can be dependent on ethnicity, whether the baby's body temperature is appropriate, also whether there's any jaundice involved. There are tons of neonates and infants that get jaundice, so we have to keep that in mind as well. Age is also a factor. Babies that are firstborn have the bluish to purplish skin color, that modeling that we know all so well. And generally that will change as early as 24 hours of life after there's been adequate oxygen exchange. The other thing that can be a factor is dryness. Babies have just spent a lot of time in amniotic fluid, and the skin in neonates and infants does not exfoliate once born as well as adult skin does. So we see that peeling effect occur. If there are three key takeaways that I would like frontline nurses to remember from this presentation, even if you are not spending time day to day with neonates and infants, it would be first to remember that emollients are our friend. Emollients can help make the skin barrier stronger. The second thing to remember is if there are abnormal skin conditions that are occurring in neonates or infants that you're taking care of, that you're unfamiliar with, please take 5 minutes and do just a little bit of research on those actual skin conditions. That's going to be what helps you take better care of your patients. And also the last thing is to remember to pass along that knowledge to the families, the caretakers that are going home with these babies upon discharge. Lots of parents and grandparents only know basic skincare as what they've learned or they've done with other children, and sometimes they're not educated on how sensitive and gentle baby skin is. So just pass that along to them so that they can take as good a care of the skin as you had up until the time they see the pediatrician, and then they'll get some further guidance.